leads us to our live Q&A with our speakers and our panelists, and Dr. Ruth Ann Crystal will be moderating that session. We do see some of the questions coming in from Q&A. We also received some of the pre-registration questions, which we will try to go through. There are a couple questions that might be most relevant to actually session 2, in particular, some of the vaccine questions that Dr. Schaefer will be addressing. And so that might be a save for then, but otherwise I'll let Dr. Crystal take the helm. Thanks.
Hi, everyone. So we have quite a few questions here, and I'd like to start out with the first one. This one is hopefully for Dr. Levy. Does the long COVID diagnosis has major and minor criteria? Since there are a constellation of symptoms which can occur, how can we make sure that we're able to diagnose correctly? Is this a diagnosis of exclusion?
So that's a great question. This is a clinical diagnosis, and for symptoms that have been present for at least 3 months, relapsing and remitting. And again, it may be a diagnosis of exclusion, but I think I would say it's also a diagnosis of inclusion, given that we think this is not a rare syndrome. Dr. Bonilla, what else would you add to that?
Yes, the problem we don't have a biomarker for this kind of condition. I think there's a lot of research going on now with a potential changes in cytokine profiles, changes in the immune system, evidence of microbiome dysfunction and mitochondrial dysfunction, but it's not a definite biomarker at this moment. And the diagnosis have been relied on only in the clinical symptoms. And the history can tell about the infection or possible infection with a SARS-CoV that match with the have been described. In base of this one, this kind of criteria have been make the diagnosis, but there's no, like you state at the beginning, there's no established or definite biomarker for this kind of condition.
And Dr. Bonilla, I know that you're working on some EMR tools that would help physicians think about this diagnosis, but it is really once a syndrome has been identified, correct?
Yeah, I think we are early in when we organized our clinic, we established 29 symptoms based on what have been published and try to make a cluster of the symptoms that define the different kind of conditions. This kind of symptom, for example, for chronic fatigue, the severe incapacitated fatigue, the brain fog, unrefreshing sleep, the post-exertional malaise, orthostatic intolerance, those kind of criteria or answers in the patient's questionnaire can lead us to suspect that possible have ME/CFS, or people have experienced a severe tachycardia with changes in position, maybe suggest possible paths. But it still is only we need to define these things better. I think the research is going to be may ask to clarify, like in the definition have been defined, like a multiple organ have been involved, and the pathobiology show these remains of virus or pieces of the virus in all organs, from the brain to the lungs, to the muscles, to the heart, to the kidneys and liver. And this can explain possible the multiple symptoms that we see in this kind of patients. So time is going to tell us and maybe give you more light about how we can define this kind of conditions. Like we talked before, there are multiple viruses can trigger this kind of problem. Long COVID is not a new problem. If you look at other coronavirus, like a SARS in 2002 in China, people who recovered ended up having symptoms like a mimic long COVID. The same thing happened in MERS in Middle East, and they show people who recovered, they have the same kind of symptomatology. So the whole symptom, the whole disease is very complex, and many things can trigger or target this kind of conditions. And science is going to make us to better understanding of this kind of problem. For example, the MICS for kids, they have shown evidence of possible is that mimicry of the virus can trigger this kind of inflammatory response in pediatric populations. So time is going to help us. I can be optimistic, and maybe years from now, we're going to have a better understanding. There's a lot of interest in this illness, a lot of research going on. So hopefully the future is going to be better for these patients.
Thank you both. We have another question for Dr. Bonilla. What is the difference between long COVID and ME/CFS?
Okay, my personal opinion, I remember very well when we started doing our first treatment trial for acute COVID, the Lambda trial. And we are on one side, they were talking about many things in the patients and what's going on with papers. And I started observe some people that finish the trial, have some symptoms like are identical what a patient has seen in my ME/CFS clinic. So I was talking with my colleagues, and I mentioned about possible we're going to see this kind of disease in this population. There are kind of comments that say like, Hector, you see ME/CFS and everything. And now we know it's a reality. We have a very complicated problem. There is no new problem, have been neglected for decades. If you look at the statistics I present about the clusters of this illness in 1935, describing in LA, a cluster of this kind of conditions, post-viral conditions. And for me, ME/CFS is one part of the spectrum of the whole condition that we see in patients with long COVID. And the same thing, we see people with a mild COVID symptoms or people with very severe symptoms is what we see long COVID populations with ME/CFS. So it's no separation, maybe different paths is part of the whole syndrome. ME/CFS is part of the whole syndrome. The cardiopulmonary symptoms could be part of the health syndrome. Dysautonomia is the same thing.
Yeah, and I just wanted to add to Dr. Bonilla's very eloquent explanation of that. The NASEM definition in the report has really made it a point to say it's not, either or mutually exclusive. It's both and. So you could have long COVID that manifests with the ME/CFS phenotype or the POTS phenotype or the, XYZ. And so it's a syndrome of syndromes. So long COVID itself is an umbrella term for many subtypes under that umbrella.
Okay, thank you. We have a few questions coming in now about supplements. There's been 3 different questions. People wondering about using different antioxidants during acute COVID that might help to prevent long COVID. Also talking about other supplements like L-arginine and others, including CoQ10 and NAD. Are there any particular dosings or formulations that you find helpful? Dr. Bonilla, do you want to take this one? Or
Yes, so it's this area need to be very careful. There's no data that we're able to recommend that one supplement or the other one. There's only one clinical trial, was placebo-controlled trial done in ME/CFS. They show the combination of CoQ10 with the NADH show some benefit in people with ME/CFS. And there are some possible supplements that enhance mitochondrial function. We need to do a clinical trials. We cannot keep on speculating one supplement or the other ones. The only way is try to see what happened. Many of the supplements in the market, they don't absorb. So they go directly from the mouth to the toilet. And people keep on spending a fortune in this kind of supplements. I think we need to organize clinical trials, placebo-controlled, try to put on rest what is working, what is not working.
I totally agree with Dr. Bonilla. And I just wanted to add, there is one study that came out of, I think, Denmark in Lancet Regional Health in Europe, and that's the high-dose CoQ10 versus placebo for post-COVID or long COVID. again, multiple more studies need to be done, but this one did not find a benefit in that research study. So.
Okay, thank you. We do have a question here about small fiber neuropathy. For long COVID small fiber neuropathy, other than gabapentin, are there any treatments that can help with the symptom management and ideal healing of the peripheral nerves? Dr. Miklas, would you like to take this one?
Sure. So, unfortunately, treating small fiber neuropathy is really just symptomatic treatment, like really all the treatment we're doing in long COVID. So I think, that question is just asking about how do we treat neuropathic pain? So, there's lots of probably review articles out there and lots of medications to try. I mean, gabapentin is probably the most common to start, but then tricyclics like nortriptyline we use a lot, or Cymbalta. Of course, side effects can be an issue, but it's typically oral neuropathic pain medication. Sometimes naltrexone can help the pain as well, and that's been demonstrated in fibromyalgia and trials. But yeah, it's usually just the typical treatment of any kind of neuropathy pain. And then the important other point to mention is, if you diagnose small fiber neuropathy, don't just assume it's COVID. There's dozens of other causes, and we always check for a bunch of lab tests, from vitamin deficiencies to other autoimmune conditions. And that's probably all on up to date as well. You can look into that.
And then we did have a question. Someone had asked, what's the maximal dose of naltrexone that you give? Dr. Munia?
Okay, yes, the naltrexone is a drug have been used as approved by the FDA for treatment of people with alcohol problems. And this kind of drug have been used in people with in the opioid epidemics, try to reverse the opioids effect in this kind of population. But the low doses, it has been used off-label and empirically for many conditions without nobody study what low doses does in patients. We know the pathobiology, or the thing we don't learn from naltrexone is based on the regular doses. There's no single study done at low doses. And what low dose is more like an arbitrary number. I think many people can say it could be 0.5 to 4.5, or 0.5 to 6 milligrams, 10, 50 milligrams, or ultra low doses in the micrograms levels. This is an area, again, we are practicing medicine without any basis or how those medications work or perform in those patients. Again, develop randomized clinical trials and try to understand those drugs is very important. And the knowledge we are going to get is by doing collaboration as well as randomized clinical trials, placebo control.
Okay.
But the doses I use in the clinic are between 0.5 to 6 milligrams. I have a few patients that have a higher doses, the people who experience from 5 to 6 a significant improvement go higher. And I have a couple of patients that response to 10 milligrams, have a significant response to 10 milligrams, marginal response to lower doses. So we don't know how high is the low doses or LDN.
Thank you. We've had a couple questions about what people can do and what they can take, including metformin and Paxlovid, to help prevent long COVID. And they wanted to know the statistics on that. Dr. Gang, do you want to talk about that?
Oh, sure. And I open and welcome, of course, the rest of the panelists to chime in about this. And again, the caveat to a lot of this is, as Dr. Bonilla keeps saying, is we need more data. So a lot of this, of course, we're thinking about our network of other clinicians who are in this field and experts. And so a lot of this is more expert opinion rather than evidence-based recommendations. I do want to just make sure we emphasize that. So there are some data to, point to from a post-hoc analysis from a clinical trial looking at acute COVID treatment, those who received metformin, those who didn't. And the follow-up surveys that they did in terms of symptom assessment and long COVID outcomes that showed potentially suggested reduction in the rate of long COVID with metformin use in the acute COVID setting. However, it's again, post hoc analysis, one study, and there's other studies that need to be done as well. And right now, looking at up to date and NIH recommendations, et cetera, it's not part of the guidelines to say that metformin is used acutely to prevent long COVID. There are more data to suggest that vaccines, though, could be effective in preventing long COVID. There's actually systematic reviews, and I encourage all to look into that as well. So that area is still being debated, and I think more data is needed. Paxlovid is another, really important question. I was just actually typing an answer to somebody who asked, does the use of Paxlovid with the initial acute COVID infection decrease the risk of long COVID or post-COVID? And also a related question, which Dr. Miglis, touched upon briefly, is what about Paxlovid or antiviral use when you already have long COVID? Again, these are all being investigated. Some of the studies that are mixed results for the acute COVID and preventing long COVID are mostly observational or simulated clinical trials. What we really need is, of course, a placebo-controlled trial, really looking at the different intervention arms and then having that prospective follow-up for long COVID. And so some of the EHR studies showed that for those who took that 5 days, who are at high risk for severe disease, seem to have lower incidences of how they defined long COVID outcomes. Whereas other studies did not, including recent ones from UCSF, as well as another study that was published in Annals, that most of the outcomes did not seem to have a difference. So again, it's mixed results. And then, in terms of Paxlovid during long COVID, we in the Stanford Collaborative ran our own initial clinical trial in 155 participants, published in JAMA Internal Medicine. We, at least from this study, and from this cohort, did not find a benefit for some of the most common long COVID symptoms, such as fatigue and brain fog. But there are other studies ongoing right now, including a large one from the NIH Recover Initiative, and they're also testing a longer duration. So we tested 15 days. They're going to test 25 days as well. So it's still an active first step, and we're going to see what more data will show.
Thank you. And then this one is for Dr. Levy. Are there symptoms of long COVID that are mostly self-limiting? Are there cases when it can continue to progress, and for how long?
I think that the manifestations can be extremely protean and variable. I'm really impressed with the broadness of the current iteration of NASM. And I think that it's really important to use the standardized definition to be able to look at our prevalence of long COVID with current Omicron variants and future variants. I don't know if I answered the question. Hector or others, what do you think? My sense is there's a lot of individual variability in the main symptom types, in the syndrome types.
Yes, we know people who get COVID, over 94% of the people recover back to normal. The rate of recovery is changed. There's no clear pattern or see these people with a mild disease recover faster than people with a severe disease. There's no pattern to separate these kind of groups, but we know majority of the people getting better. Around maybe 6-7% of the people remain with symptoms, and those symptoms can change. What would be from mild symptoms to very severe symptoms, like we know have been described over 200 symptoms in patients associated with long COVID symptoms. They are, when you look at our populations, the 29 symptoms that we explored, we found fatigue was the predominant symptoms in close to 85% of the patients, followed by brain fog and refreshing sleep. Maybe we see this kind of patient because we are referral center, could be a bias over group. People with severe condition come to the clinic, and we see this kind of more severe cases like have been reported by other groups. But there is no pattern or which symptoms recover quicker than the other ones, and who is going to recover versus not recover is a question still very, well defined. We know females have been more affected than males. We know males, they go more frequently to the hospital with a higher mortality. So acute infection is more severe in males than females. All the long COVID symptoms more frequent in females. And we are doing some in vitro studies and looking at mitochondrial function. And preliminary data show mitochondrial dysfunction is more prevalent in females than males. So maybe there are different kinds of the pathobiology of this condition according to sex. As I mentioned before, the research is going, a lot of information is coming, and we still don't have no the final answer. Maybe in 1 or 2 years from now, we're talking about different things than now.
Yeah, and I'll just add, I thought there was a New England Journal review in 2024, a VA analysis that looked at post-COVID symptoms 1 year out. And interestingly, in pre-Delta, it was about 10%. In Delta, it was about 9% and 5% in the vaccinated. And with our current Omicrons, it's in the 7% and 4% with the vaccinated. So again, a different definition than the NASM, but nice to see that with variants, it does seem to be, our current variants, it does seem to be decreasing in prevalence.
So I think we might have time for one. Well, we've kind of answered this. There's been several people asking how to instill hope, and do we have a sense of factors that will predict some people will recover? How, Dr. Bonilla, do you want to?
I think it's difficult to, I don't have my crystal ball working today to predict who is going to recover or not. Maybe in the future, we are able to identify maybe genetic markers, factors that can be make them to recover. Maybe microbiome changes. It's something kind of interesting. I came out across with a kind of paper and looking for the microbiome and how to use fecal transplant as a way to treat many conditions, because they assume like this dysbiosis is the driver of this kind of inflammatory process. And they're looking for sleep disorders in patients with a long COVID. And they look at the dysbiosis in those patients. And they use a healthy microbiome. I think for the protocol was for a month. I think they use every week for a month. And they're looking for how many people have improvement in the sleep disorders. And they found out significant improvement in people who get a fecal transplant. And when they're looking for the microbiome, the people who respond, the microbiome is similar to the healthy donor microbiome. So it's kind of areas is interesting to know. And there are many things going on. I think excited. But know like the bright light to tell me, oh, this is the way it's going to be. This is the cause of this problem and how I come to tackle the problem. I am very optimistic about it. There are some findings. There's a lot of interest for the medical and research community in this kind of topic. Many things that we are didn't understand before weren't able to make clear. For me, mitochondria are possible have a very important role in this kind of condition, and how this was affected and how we can fix it is not clear for me how to do that. And we are doing like empirical clinicians. They try many off-label therapies, and sometimes we make mistakes. So I suggest to the people when they're going to use off-label therapy, be sure it's not going to be harm for the patients. And if you're going to use something that potential side effects or harm to the patient, it's better to refer to a clinical trial. We cannot play with the patient's health and life. And I suggest to the providers, it's better to tell the patients, refer to a clinical trial when you consider different drugs than potential side effects.
Thank you so much to our panelists, and thank you, Dr. Crystal, for moderating the first session. We are just to keep things moving as well. And if you have other questions, if there's time also at the second Q&A, we're happy to try to fit those in as well there.